Okay, good afternoon, everybody. Thank you for joining us for today's InCHIP lecture series. I am very honored and excited to introduce my colleague and very good friend, Dr. Jessica Fish, who is the speaker for this lecture series. Dr. Fish is an assistant professor in family science as part of the School of Public Health at the University of Maryland, College Park. She's also the Deputy Director for Research and Evaluation at the University of Maryland Prevention Research Center. Her background is that she received a Ph.D. in Family and Child Sciences with a special emphasis in family experiences at Florida State University. And after that, when I met her, she was a postdoc with Dr. Stephen Russell at the University of Texas at Austin. Currently, as a faculty member, she studies the sociocultural and interpersonal factors that shape the development and the health of sexual and gender minority youth and adults. In particular, she's been a leader in the identification of modifiable factors that contribute to the disparities that are very well documented among SGM, sexual gender minority young people and adults. Dr. Fish is my and many others' go-to scholar when we want to better understand and contextualize some findings we have, especially related to SGM health disparities around alcohol use. And as you'll see today, mental health is a field that Dr. Fish is quite an expert in. I think that if we could have anyone discussing the mental health of SGM people, Dr. Fish would be the go-to person to ask. She did co-author a paper titled Mental Health in Lesbian, Gay, and Bisexual Transgender LGBT Youth in the Annual Review of Clinical Psychology just 5 years ago that's received over 640 citations. And so I think that goes to say that Dr. Fish knows a lot about the topic and is really quite an expert and the person I look to for the information in this field. So please join me in welcoming Dr. Fish for her title called Future Directions in Understanding and Addressing Mental Health Among LGBTQ Youth. This lecture is in recognition of the World Mental Health Day, which is a few days from now on the 10th. Just to give you a little overview, Dr. Fish is going to present her lecture for about 45 minutes. We're going to plan to save some time at the end for question and answers. And so if you have any questions that emerge during her talk, you could put them in the chat and I'll try to organize them and bring them up to Dr. Fish at the end of the lecture, or you can raise your hand when Dr. Fish has finished her talk, and I can unmute you and call on you to talk. So without further ado, welcome to Dr. Fish.
Could you please start sharing your slides?
Absolutely. Okay. Everything okay? Everyone, I'm so excited to have you here. Thank you to the organizers for inviting me to be here to speak with you all today about future directions and conceptualizations and understanding and addressing mental health among LGBTQ youth. I'm going to be focusing both in this talk on my own work as a researcher advocate, along with the research and advocacy work of others on this topic of LGBTQ youth development and health. Specifically, I want to situate the current talk with a background on how historical changes have created the possibility for LGBTQ youth to understand themselves and come out during adolescence. I'll then review some of the research, the current research on strategies to address LGBTQ youth health, with showcasing the gaps that remain in large-scale evidence-based prevention and intervention strategies. I then argue that scholarship on LGBTQ youth mental health has reached a critical turning point for action. And framed in the context of translational science, I'll propose 6 distinct but interrelated considerations to advance future research and ultimately programs and strategies to address LGBTQ youth mental health. So to start, why is LGBTQ youth mental health still urgent, as this seems to be a topic of conversation from time to time still? 2 decades of research, including recent federal data, show that LGBTQ youth have disproportionately high rates of depression, suicidality, disordered eating and weight behaviors, alcohol, tobacco, and marijuana use, illicit drug use, STI, HIV, teen pregnancy, when compared to their heterosexual and cisgender peers. And these disparities have been well linked to LGBTQ youth's experiences of stigma, discrimination, harassment, victimization, bullying, and rejection specifically linked to their sexual orientation and/or gender identity. However, when we reflect on the arc of social change for LGBTQ rights, few societal attitudes and opinions have changed as quickly as those regarding sexual minority and, to a lesser extent, gender minority people and rights. In a period of less than one generation, we have gone from almost complete silence and invisibility prior to the 1960s to greater legal and social acceptance only half a century later. Large-scale social surveys, including the General Social Survey, the Pew Daily Tracking Survey, and the Gallup poll, show that attitudes towards same-sex people and their relationships have steadily improved in the last 40 years. We have also witnessed the repeal of harmful policies such as Don't Ask, Don't Tell, and the enactment of laws that provide protections for LGBTQ people and their families, such as marriage equality and adoption rights. And the visibility of LGBTQ people in mainstream culture, media, and politics provide additional evidence for how much things have changed with regard to LGBT people and their communities. For example, the General Social Survey, a U.S. nationally representative survey that monitors trends and opinions, has been tracking attitudes towards LGBT people since the early 1970s. And this particular line here represents the decline among people in the United States who believe that sexual minority people, lesbian, gay, and bisexual people should not be allowed to teach adults in a university setting, which also reflects kind of a proxy for broader social attitudinal changes over time. And these changing attitudes, along with increased visibility of LGBTQ people, provide a historically new possibility, and that is to be out as a teenager. These data points reflect the average age of coming out or disclosing one's non-heterosexual sexual identity to family and/or friends in studies dating back all the way to 1979. An overview of these studies reflect an appreciable and steady decline in the age at which youth come out as LGB, and similar studies have recently shown that the same effect has been occurring among trans and gender minority populations. It is safe to say that changing social attitudes and visibility now afford youth the ability to understand themselves at earlier ages, at a stage in the life course when sexuality and identity are core tasks of development, and thanks to the visibility and access to the internet, to have the language and sexuality to understand and define their diverse sexual orientations, gender identities, and expressions. And as more youth come out, many people presume that the mental health vulnerabilities that have been documented among LGBTQ youth in research may ultimately be overcome in younger cohorts. That is, that new legal and social acceptance present new pathways towards health and wellness for contemporary cohorts of LGBTQ people, or to put it simply, that things are better. But this conclusion has not been found in the data. Instead, a paradox emerges when comparing the arc of social change to the health status of contemporary sexual minority adolescents. In fact, my colleague Dr. Stephen Russell and I argue that the intersection between changing social norms and declining age at coming out have created a collision between normative adolescent developmental processes on the one hand and individual development for LGBTQ young people on the other. Specifically, as more LGBTQ youth come out in early adolescence, they start to navigate cognitive, interpersonal, institutional, and social and cultural contexts in which LGBTQ identities and issues are particularly complex. So what do I mean by this? Well, with the onset of puberty, youth become aware of same-sex attraction and different gender identity and expression. This occurs at a time when youth are particularly vulnerable to peer attitudes, influence, and victimization. Peer and peer approval matter so much to the self-esteem, well-being, and self-concept of young adolescents, more than any other time in life. Peer expectations and policing of quote-unquote normal sex, gender, and sexuality are also incredibly strong during early adolescence, and youth are often socially sanctioned if they violate traditional gender or sexuality norms during this time. Youth at this time are also still actively developing understandings of empathy and ethical moral reasoning, which lead them to perpetuate victimization and bullying at higher rates than at any other developmental stage. There is, in fact, a lot of research showing that victimization peaks in early adolescence and declines as youth age, although this has not traditionally been the case for LGBTQ adolescents. And unlike the generations before them, LGBTQ youth today come out at a time where they are financially and emotionally dependent on family and required to attend school. Whereas prior generations of LGBTQ people would often wait until they were out of school, out of the home, and financially independent from their family of origin, providing them with more resources for coping in instances of rejection and cutoff. And so my colleagues and I argue that with improved social attitudes, LGBTQ youth feel okay to come out, but then are uniquely vulnerable to peers and family who may not accept them in contexts that they cannot leave. And this is supported by research that demonstrates that youth who come out are more susceptible to peer victimization, family rejection, family harassment, and abuse than youth who conceal those identities. In other words, these broader socio-historical processes of growing acceptance and, with some exception, improved policies now collide with normative developmental processes in ways that make contemporary LGBTQ youth vulnerable to poor mental health, just like the generations of LGBTQ people before them. I want to pause and be clear. I'm not saying that LGBTQ youth should not come out. In fact, even with increased victimization and harassment, there is research that also shows that youth benefit from disclosing their LGBTQ identity and finding support. Instead, I'm drawing attention to the fact that youth are now coming out in a context that has not adapted to the degree necessary to support their positive development and mental health. So these issues related to the developmental collision are also critical when we consider that, in addition to coming out earlier, more youth are understanding themselves to be sexually and gender diverse than ever before. Many of you likely saw the news headlines a few months ago where the Gallup poll found that 1 in 6 people in Generation Z identify as LGBTQ+. In fact, when you look at the change across generations, the trend is fairly pronounced. With each generation, more people identify as LGBTQ. And in the most recent generations, Generation X, Millennials, and Generation Z, we see an acceleration in the number of people who understand themselves as LGBTQ as they get older, particularly post-marriage equality, with almost 16% of Generation Z self-identifying as being part of the LGBTQ community. And what about today's generation of young people? We find similar, if not even higher, numbers of LGBTQ representation. Here are the data from the most recent National Youth Risk Behavior Survey, which is fielded by the CDC and collected from middle and high schoolers across the country. It finds that 3.4% of youth identify as either transgender or questioning their gender identity, and 15.7% identify as LGB or questioning their sexual orientation. And these numbers remain high in places that are not necessarily affirming to LGBTQ people. Importantly, with each new national survey of adolescents, we observe that LGBTQ youth continue to show disparities or differences in suicidality, mental health, substance use, and peer harassment. In the figure presented here, I'm showing you the differences between transgender and cisgender female and male youth from the CDC's 2019 Youth Risk Behavior Survey, where we see stark differences in the proportion of youth who report a suicide attempt, feeling sad or hopeless, any type of substance use, various types of peer harassment, and in particular, feeling unsafe at school. And these same disparities are also present when comparing heterosexual and LGB youth in the same data source. So when we weigh the increased number of youth who identify as LGBTQ and the persistence of mental health and substance use disparities, we are left wondering, where are all the programs for LGBTQ youth mental health? At least that's where I end up. Unfortunately, outside of sexual health, there remains limited research that systematically develops and tests LGBTQ-related or LGBTQ-specific youth mental health promotion strategies across contexts. That said, I do want to recognize the 3 main areas in which evidence-based strategies have been identified: individual level treatment, school policies and programs, and state level policies. Although LGBTQ identities and issues have made their way into the ethical guidelines and standards of care for most mental health organizations like the APA, and there has been some clinical innovation for interventions for LGBTQ young people, it still is a very nascent area. Research advancements and clinical strategies include attachment-based family therapy, relational-focused therapy, and John Bachingis's ESTEEM, which show promising outcomes for LGBTQ young people and their families. These models of treatment offer preliminary efficacy for improving LGBTQ youth mental health, but are still in the process of broader implementation and testing. These clinical approaches are an essential step in developing and altering evidence-based treatment strategies like cognitive behavioral therapy, like attachment-based therapy. But we have to recognize the limitations of individual treatment. Of course, individual treatment is a necessary approach to bolster mental health for LGBTQ youth. That's not what I'm saying here. I just want to note that many people who need mental health treatment never receive it. Less than half of adolescents with depression and only 1 in 8 people over the age of 12 who need substance use treatment receive it. Therefore, along with developing empirically supported therapeutic strategies, there needs to be an effort to diversify delivery models of LGBTQ sensitive, affirmative mental health care to broader swaths of the population. Schools are perhaps the single most studied context for LGBTQ youth. Gender and sexuality alliances are school-based extracurricular clubs and programs that convene LGBTQ youth and allies. They are typically supported by an adult advisor at the school, and the GSA acts as a resource for support and socialization of youth. The presence of GSAs is associated with less school-based victimization for LGBTQ youth and is prospectively linked, thanks to a recent study by Paul Poteet, to reduce depression and anxiety for youth who actually participate in these programs. LGBTQ inclusive school policies are also associated with student perceptions of school climate, experiences of victimization, and LGBTQ youth mental health. These studies provide strong evidence for the positive benefits of LGBTQ specific school programs and policies for supporting the positive development and mental health of LGBTQ young people. Lastly, state level policies reflect large-scale upstream health promotion strategies for LGBTQ youth. The field of structural stigma, or the societal level conditions, cultural norms, institutional policies that constrain the opportunities and resources of those that are stigmatized, provides compelling evidence that state policy environments, such as the presence of a non-discrimination policy that actually enumerates or names sexual orientation or gender identity as a protected class, these policies shape the mental health of LGBTQ youth. Sexual minority youth, for example, who live in states and cities with more protective policies are less likely to experience victimization, participate in substance use, and report suicidal ideation. Less robust but emerging data are showing that studies that highlight the structural stigma operates similarly for transgender and gender minority populations, but this is an area that is in need of a lot more research. These strivings in individual, school, and policy level interventions remain critical components for addressing the mental health of LGBTQ youth and deserve continued attention. Equally necessary and urgent, however, is the need to address the negative space in the body of science, the overwhelming dearth of research surrounding large-scale prevention, intervention, and health promotion programs that specifically address the mental health needs and experiences of LGBTQ young people. Despite some initial progress, for example, AFFIRM, which is a group-based affirmative cognitive behavioral therapy program developed by Shelley Craig and Ashley Austin, a recent review of LGBTQ youth interventions for mental health, substance use, and violence identified only 9 evidence-supported interventions for sexual and gender minority youth mental health. But the majority of these interventions were individual-level psychological therapeutic interventions, pharmacological or medical treatments such as puberty blockers, and that is just, or policy, and that is just abysmal given what we know about LGBTQ mental health and how pervasive it is. So with the increased inclusion of sexual orientation and gender identity measures in population-based studies and the rise in federal funded studies that focus on mental health of LGBTQ people, we now have a compelling and rapidly expanding science on the mental health of LGBTQ youth. And in particular, in the last decade, studies have been able to identify and examine a multitude of contributing factors and processes complicit in undermining the mental health of LGBTQ youth, modifiable factors that are contributing to mental health. This research identifies these factors and should be addressed, to improve LGBTQ population health and are unique to LGBTQ populations. So for this reason, I situate my recommendations for future scholarship and practice in the context of translational research. As many of you likely know, translational science investigates how basic science is transformed into interventions that improve the health of people and populations. There are many translational research models, and the field of translational science, including dissemination and implementation, has grown exponentially in recent decades. One of the more widely used models, which I illustrate here, is the knowledge to action framework. It's also used by the CDC, consists of 2 distinct but interrelated and mutually informative feedback loops: the knowledge creation cycle and the action cycle. If you look at this updated feature from Graham, I argue that scholarship on LGBTQ mental health research has primarily remained in the knowledge creation phase, with very few studies venturing into the action cycle, specific to mental health I'm talking about here. Sexual health, I would argue, is different, but mental health, absolutely. And so few have ventured into this action cycle, and this is where we potentiate our knowledge to address and combat LGBTQ health inequities. Yet, translation of evidence into practice reflects a necessary next step that we need to take to address mental health among LGBTQ youth at broad scale. So in considering this next phase for LGBTQ mental health research, I raised 6 considerations that I believe will help advance research and translation efforts to address LGBTQ youth mental health. These include framing LGBTQ health disparities in a life course perspective, expanding notions of mental health, attending to the complexity of youth context, acknowledging heterogeneity, leveraging community resources, and fostering team science approaches to inquiry and application. I'm going to tackle each of these in succession. So first is framing LGBTQ health in the life course. This is not necessarily a new concept. Phil Hammack has written pretty extensively on this and quite beautifully on this. But the application of life course theory to LGBTQ health remains pretty novel. Adolescence is a critical developmental period for mental health, symptomology, and substance use onset, which have implications for mental health across the life course. Yet gaps remain regarding how developmental timing, developmental sequences, and the constancy of specific experiences like stigma shape LGBTQ lives and its association with mental health, both in the moment and later in the life course. Although we've been limited by a lack of longitudinal data that include measures of sexual orientation and gender identity, there is a dire need to understand how experiences early in life contribute to later health and wellness among LGBTQ people. In writing and thinking about this, it would be easy for me to just call for more longitudinal studies. However, for me, it's most important to consider the actual design of longitudinal research so that it can actually identify modifiable mechanisms and critical periods for prevention and intervention. So research that seeks to identify, 1, the degree to which early experiences shape mental health, the differential impacts that these experiences have, and how the timing of these experiences shape mental health across the life course. These would significantly advance policies, programs, and prevention strategies aimed at addressing mental health for LGBTQ people and young people in particular, but also the optimal timing for these interventions. I'll give some examples of this a little bit more in a minute. First, I want to talk about this example, which was a study that I actually conducted with myself and 2 of your colleagues at UConn, Drs. Ryan Watson and Dr. Beth Russell, where we sought to understand how early experiences in parental-child relationship quality and parental autonomy granting might shape alcohol abuse in later adulthood among sexual minority girls and women. Using data from the National Longitudinal Study of Adolescent to Adult Health, we found that youth who reported same-sex attraction had over 2 times the odds of meeting a DSM-4 criteria for alcohol abuse or alcohol use disorder later in adulthood. And that this disparity was partly explained by deficits in parental relationship quality during adolescence, whereby those who were same-sex attracted reported lower parental quality, and this in turn predicted higher odds of meeting DSM-4 criteria for an alcohol use disorder in adulthood. Importantly, as shown in Model 2, these disparities or differences in parental relationship quality were already present in Wave 1 when participants were between the ages of 13 and 18, which suggests that these family ruptures start early in the life course and have long-lasting consequences, particularly in this study for sexual minority women's health. In fact, my colleagues and I have conducted several studies to try and pinpoint how early these disparities in mental health and substance use emerge. And what we found is that sexual orientation and gender identity related mental health, substance use, and victimization disparities are already present in late childhood and early adolescence. For example, in these figures, we use data from the California Healthy Kids Survey, which document age differences in alcohol use, among other substances that I don't show here, and depressive symptoms. And what we find is that sexual orientation differences in alcohol, cigarette, and marijuana use start before the age of 12, and that disparities in depressive symptoms start before the age of 11. Whereby lesbian, gay, and bisexual boys and girls report elevated rates of substance use compared to their heterosexual peers and more depressive symptomology than their heterosexual peers, starting at early ages, and they remain at elevated risk all across adolescence. Although not shown here, we also see that this pattern emerges when we explore differences by gender identity. It's a similar pattern, but the differences are even more robust, and there's a greater acceleration of the difference across the ages. And it's not that LGBTQ youth are inherently more prone to poor mental health and substance use, but that the social conditions in which they develop lead to vulnerabilities for mental health and substance use. So for example, these figures from the same data, demonstrate disparities in bullying by perceived sexual orientation between different sexual identity and gender identity subgroups. And you can see that there's stark differences in the proportion of youth who experience these kinds of harassments, and they remain elevated across adolescence. In another study that I conducted with Alexa Martin Story and myself, we used multi-informant longitudinal data to understand how this operates across childhood and young adulthood, and found that youth who eventually reported being LGB at age 15 actually reported disparities in peer harassment as early as age 9, as did their teachers. So the teachers also reported that they witnessed greater victimization and harassment when they were 9 years old. And so this further corroborates the idea that LGBT youth are experiencing stigma at very young ages and even in childhood. And so these findings suggest that current strategies to support LGBTQ youth, for example, like gay-straight alliances or gender and sexuality alliances, are available after disparities have already emerged for this population. From a prevention standpoint, these findings imply that experiences in childhood are shaping LGBTQ-related health, and thus require creative strategies to assess how early interactions may be disproportionately represented or uniquely impactful for children who later understand themselves to be LGBTQ. Although there's much work to be done in this area, it would benefit researchers, practitioners, and policymakers and educators to consider how to capture and integrate issues of LGBTQ inclusivity and diversity at young ages. So Katie Clark, for example, in their dissertation found that including LGBT inclusive curriculums and images in elementary school classrooms improved children's knowledge of same-sex relationships relative to children in control conditions. And so age-appropriate interventions that incorporate sexual orientation and gender diversity could help to reduce bias in children and ultimately save early exposure to stigma for LGBTQ youth. But we need a ton more work in this area. Okay, on to consideration 2. These early considerations get a lot of time, and then I'll speed up a little bit because I know time is starting to get tight. So expanding notions of mental health. It is undeniable that LGBTQ youth experience stark inequalities and major markers of mental health. Nevertheless, mental health is not specific to mental health conditions, and there is growing interest in a broader construct of emotional well-being. Emotional well-being reflects concepts of social and community connection, life satisfaction, positive affect, finding meaning or purpose in life. These are factors that are readily influenced by stigma, discrimination, and marginalization. Emotional well-being is a population health issue, and it's actually a robust predictor of health morbidity and all-cause mortality. In fact, the National Institutes of Health has several current calls for funding to assess and address emotional well-being and its components, including isolation and social connection. Although specific mental health conditions like depression and suicidality are necessary targets for LGBTQ health initiatives, researchers focused on the broader construct of well-being could offer unique prevention and health promotion strategies for LGBTQ youth, including programs and strategies that do not require clinical intervention. Concepts of emotional well-being dovetail really nicely with models of positive youth development, which guide many of the nation's youth policy and program initiatives. It's rooted in prevention. Positive youth development reflects an approach to youth engagement that seeks to leverage youth's inherent strengths to promote positive functioning in the context in which they're already developing, like families, schools, and communities. So positive youth development programs promote social connection, social-emotional competence, self-determination, self-efficacy, future orientation, and other types of pro-social behaviors. Although positive youth development is widely recognized, its application to LGBTQ youth has been slow. Pioneering work in this area has been conducted by Dr. Russell Toomey at the University of Arizona and his colleagues, and they find that developmental assets appear to operate similarly for heterosexual, cisgender, and LGBTQ youth in both their form and protective function, which is great news. However, LGBTQ youth experience deficits in many of these internal and external assets, which leave them vulnerable to lower well-being, poor mental health, and substance use. So there are many avenues to explore how positive youth development operates for LGBTQ youth, and these initial applications are promising because many youth programs adhere to positive youth development models such as 4-H or Scouting. Therefore, minimal adaptations to existing programs could help make them more welcoming for LGBTQ youth and position them to better address the experiences of LGBTQ youth. And I've seen this done with 4-H to some degree, and it's been really positive. Even outside of positive youth development programs, understanding how existing evidence-based youth programs that are PYD focused could be adapted to accommodate LGBTQ youth, and it reflects one major strategy to address the current dearth in LGBTQ youth prevention and intervention tools. And this was something, there was a recent National Academies meeting. This was one of the big takeaways, is we need to adapt evidence-based programs to be sensitive, specific to accommodating of LGBTQ youth and their experiences. Lastly, the LGBTQ youth mental health literature is lacking studies that assess resilience. It is worth noting and emphasizing that LGBTQ youth demonstrate enormous strength in the face of adversity. Studies have been slow to adopt, though, strengths-based approaches and perspectives to examine how youth foster and display resilience, the results of which could help strategies to support youth's existing strengths, in addition to cultivating internal and external resources to cope with things like minority stress. Much of the current research provides implications for how to mitigate stress and harms directed towards LGBTQ people. So strategies to reduce bullying and victimization and stigma, and those are incredibly important. Those are the structural forces we should be combating. But equally important, but less often studied, are the addressable intrapersonal and interpersonal strategies that youth can use to attenuate the negative impacts of stigma on LGBTQ youth mental health, such as coping strategies or empowerment. Some emerging research suggests that LGBTQ-specific coping strategies and engagement in social justice activism is positive and protective for LGBTQ youth. Think of the work of Alex Wagaman, for example. Research focused on identifying coping and resilience strategies will be instrumental to informing large-scale prevention and intervention programs designed to help LGBTQ youth combat the negative impacts of stigma and discrimination. And then we've seen some of this in gender and sexuality alliances as well. Next, I want to consider the fact that youth experiences are multicontextual and multifaceted. So among studies that assess the factors influencing LGBTQ youth mental health, the majority focus on experiences within a single context, so schools or families or with peers or in communities. This focus has been, of course, absolutely necessary to better understand how stigma and support are associated with LGBTQ youth's mental health. However, youth's experiences is multifaceted, right? So for example, different contexts may be more or less accepting of youth's LGBTQ identity. Therefore, on any given day, an LGBTQ young person may transition from an affirming home environment to a hostile school environment, or vice versa. Youth may also work to manage their LGBTQ identities across contexts, choosing to be out in one context but not the other, or even out to one parent but not the other. And we've seen this too. So research suggests that youth who are out at school and with family are more vulnerable to victimization, but the concealment also has negative consequences for health. More generally, identity management strategies, the things I was talking about, whether or not youth are out in context, have been shown to elevate distress and poor mental health among LGBTQ adults and impacts the academic achievement of youth. Even with this knowledge, researchers have yet to really comprehensively interrogate and understand how navigating these various contextual factors impacts LGBTQ mental health during adolescence, and importantly, how these early experiences of navigating these spaces contribute to their perceptions of stigma, their what we call rejection sensitivity, work by Brian Feinstein, and mental health across the life course. Going back to that life course piece. Even within a given context, though, LGBTQ youth experiences are multifaceted. School can include both supportive and unsupportive spaces. Families can simultaneously engage in behaviors that are accepting and rejecting. Nevertheless, researchers often characterize these contexts as either accepting or rejecting. There have been several recent studies that showcase that LGBTQ youth report the co-occurrence of acceptance and rejecting experiences with family, and that these constructs are actually not correlated with one another. More recent work find that transgender people who experience simultaneous messages of support and rejection from family, so high on both of those things, have poorer mental health than both transgender people who experience overwhelming support, not surprising, but actually significantly higher distress and poor mental health compared to those who experience outright rejection, given the ambiguity and dissonance that's there. So research that is intentional about operationalizing and measuring experiences both across and within various contexts will help bring much needed nuance to how LGBTQ youth experiences with schools, peers, and families shape mental health and well-being, and more importantly, strategies to intervene in these spaces and across these spaces. Future research should also seek to assess how these multi-level and multi-contextual influences work in tandem to influence LGBTQ youth mental health and related resources. Given the reality that the strategies need to eliminate LGBTQ youth mental health disparities must address each of the multiple contexts that youth traverse. Like, we can't just have school policies, we can't just have family interventions. We need to talk about how these things work in tandem. And there has been some work in this area, so largely focused on how multiple sources of support across contexts may differentially explain mental health and well-being among LGBTQ youth, and the degree to which parental support buffers the link between victimization at school and poor mental health. Although much of this work suggests that having supportive parents is not enough to buffer the negative impacts of victimization, right? So we need an all hands on deck approach when it comes to multi-contextual factors. More challenging, but perhaps more illuminating, would be investigations of how family, school, and community contexts intersect. So, for example, how parents shape school experiences for LGBTQ through advocacy. We've seen this a lot with parents of trans youth recently, or whether and how schools can educate parents on how to better support their LGBTQ youth. So there's lots of school programs that help support parents. This could be a great avenue to include education on LGBTQ youth health needs. So investigating the nexus of these environments, that mesosystem of where they meet, will allow researchers and practitioners to better address how the environmental profiles of youth, right, holistically, help shape their positive development and mental health, and the development of multi-sectorial strategies to support LGBTQ youth mental health. So despite shared narratives among LGBTQ youth, these experiences do not occur independent of other social identities and contexts, right? Like minoritized racial or ethnic identities, sex, disability status, religion, immigration status, documentation status, socioeconomic status, so on and so forth. Intersectional perspectives of LGBTQ youth mental health and well-being are woefully underrepresented in the mainstream scholarship, with some exception, and yet have genuine implications for understanding and improving the lived experience and mental health of LGBTQ youth. Although many studies acknowledge that experiences are likely unique, for example, LGBTQ youth of color, there remains limited research that actually takes this on. That actually, we see it time and time again. We need to be conscientious of this, but the research that actually does this, that tests this, is not there. And in their content analysis and review, Toomey et al. Noted that studies are largely focused on sexual risk, substance use, and mental health problems, rather than on normative developmental processes or positive youth development processes that could be more illuminating for the things that we can do to support these youth. So similarly, few studies in their review that they had examined the process by which interlocking experiences of oppression related to both sexual orientation and race ethnicity, for example, impacted sexual minority youth mental health. This descriptive work that they highlighted is necessary and important to being able to highlight differential risk, but a focus on normative development and resilience processes for these youth are essential to understanding the lived experiences of LGBTQ youth of color, and importantly, the development of multi-level strategies to support them, right? So it's not enough to know that certain subgroups are more or less at risk for alcohol use. What's the difference in the things and the processes by which these things occur so that we can address those? In one study focused on process, so this is a good example, that influenced mental health, Paul Poteet and colleagues assessed whether parental support buffered or moderated the association between homophobic victimization in schools and mental health. And what they found is that the moderating effect was only present among LGBT students of color. It's an effect that the authors of the study hypothesized was likely related to LGBTQ youth of color's ability to adapt racial ethnic socialization messages and coping strategies that they had probably learned about race from their family and ethnicity from their family to experiences of homophobic bullying. They had that toolkit to be able to use. So these examples help illustrate that research and applied benefits of not only acknowledging racial, ethnic, and/or other social identity differences and rates of poor mental health and resilience strategies, but really to focus on the process through which they occur. So despite some advancements in this area, we need more concentrated efforts to assess these experiences in a way that acknowledges different potentials for development, like Garcia Cole told us in 1996, among LGBTQ youth of color, and the cultural and experiential differences within the moniker of LGBTQ youth of color, which deserve explicit attention. Intersectional perspectives of youth development also encourage the exploration of other social identities and experiences that shape mental health and well-being. For example, there has been growing attention to the experiences of rural and Southern LGBTQ youth and how their community contexts shape their experiences, but also their access to critical resources and strategies of resilience linked to, for example, social justice. There's also growing recognition of the experiences of disabled and neurodiverse or autistic LGBTQ people. LGBTQ youth living in situations of economic and housing instability. LGBTQ youth have been linked to systems of care or custody, like foster care and juvenile punishment systems, and the list goes on. And these all require explicit attention to distinctness and overlapping experiences related to sexual orientation, gender identity, and expression. Relative to schools and even family, there has been less research attention on the community factors that might thwart or promote health for LGBTQ youth. Yet community level factors are implicated in LGBTQ mental health. For example, sexual minority youth who live in communities with greater representation of same-sex couples, registered Democrats, GSAs, and non-discrimination school policies are less likely to engage in suicidal behavior and substance use. A more recent study showed that LGBTQ specific support factors at a community level, so things like LGBTQ community resources, number of LGBTQ centers, the number of years that a GSA was present in a school, were associated with lower substance use among sexual minority youth. However, the processes by which these community factors actually support or bolster the health of LGBTQ youth is actually really not known. Is it that youth are living in policy environments that reflect more accepting communities, or is it well-being heightened through tangible resources like youth centers, or participating in events like Pride, or the visibility of LGBTQ people through pride flags or the all are welcome here signs? We're not quite sure. So notwithstanding the impacts of state level policies, because those are pretty clear, future research might want to consider how policies are enacted and reflected in community environments, given that these more proximal factors likely mediate the impact of policies on youth mental health. From a translational research perspective, knowledge about how community differences impact LGBTQ youth are critical for developing, adapting, and implementing programs. One area of future advancement lies in partnerships with LGBTQ community centers. Preliminary research suggests that LGBTQ youth who attend these organizations report better self-esteem and lower substance use when compared to LGBT who don't engage with these centers. And these programs offer a safe space for youth to meet one another, seek social support, foster community, and engage in mental health and medical health care services specifically designed to address the unique needs of LGBTQ youth. These centers also tend to serve youth of color, transgender youth, and youth who experience economic precarity at greater rates than the general population, which means that these strategies are reaching youth that don't typically engage in other type of LGBTQ youth programs. Despite all the work that these centers are doing, there's 280 of them that are registered currently in the United States. LGBTQ youth centers have not received much empirical attention. Scholars interested in developing, implementing, evaluating, and disseminating strategies to support LGBTQ youth should consider authentic community engagement partnerships with community-based centers and the value of including these folks as experts in the process of translation. They've been doing this for decades now, and they are absolutely part and parcel clear stakeholders in advancing translational science for this population. Really quickly, this last point, if not already apparent, I believe that solutions that promote LGBTQ youth health require assimilated vantage points from human development, family science, education, psychology, public health, social work, public policy, law, medicine, just to name a few, right? It further necessitates, though, the integration of frameworks, methodologies, data sources, and findings across disciplines. So the degree to which we can continue to see fruitful lines of work mature on these important topics will hinge in large part to our commitment to interdisciplinary and team science approaches, and in training the next generation in team science approaches to addressing these pressing public health problems. So one good example of this is a recent gamified intervention that links social psychology, cognitive psychology, LGBTQ health disparities, and technology. This was a recently published protocol for a gamified, social media inspired, web-based intervention, it's a mouthful, for alcohol use for LGBTQ women who are at really high rates of disproportionate alcohol use in the general population. So this platform is part social media, part dating app, part quiz, part sharing information about how much LGBTQ women in LA are using alcohol, because what we find is that when lesbian, bisexual, and queer women understand that other lesbian, bisexual, and queer women don't drink as much as they think they do, these kind of prescriptive and injunctive norms related to alcohol use, if we normalize how much alcohol use LGBTQ population women are using, they are less likely to use alcohol themselves. And so it's a really innovative intervention to try and normalize the amounts of alcohol being used by LGBTQ women in a way that could potentially stave off and decrease the amount of alcohol use that any one person is using at that given moment. So it's a really, we need more interventions like this that are innovative and relevant, but they require expertise in multiple domains and sectors of knowledge like technology, app development, and then cognitive science. So many of us learn to do interdisciplinary work by accident, right? Through trial and error. For LGBTQ youth researchers, many of us were forced to read and integrate, back in the day, cross-disciplinary research and theory by necessity, given that relatively few scholars were doing this work even just 10 or 15 years ago. In many ways, this historical cross-pollination led to a growing field of study that has remained fairly interdisciplinary, right? I'm a couple and family therapist that got a degree in human development, that did population and public health, and I'm in a family science program and a school of public health, right? It's very interdisciplinary. And by virtue of how the field has developed, this is not uncommon for LGBTQ scholars, right? But as scholarship on LGBTQ youth continues to grow, we will, I believe, become more siloed within our respective disciplines. It is just inevitable. The science on LGBT youth is growing rapidly. It's impossible for any individual researcher to stay up to speed and relevant to all the things that we're learning. So the interdisciplinary strength that emanates from the roots of our science, however, could live on through training and education that integrates and privileges team science. So what if training programs were structured and designed to facilitate training and education among early career researchers through interdisciplinary and transdisciplinary teams, linking up social behavioral scientists to human-computer interactionists, right? What could that yield? And in addition to these strategies for developing, implementing, and sustaining these collaborative endeavors as students move through the process. Changes are necessary to improve the lives of LGBTQ youth, and Hatzabuehler has eloquently stated this time and time again. In the presence of hetero and cis normativities, policies, structural changes aid in the protection of LGBTQ people. However, the impact of these policies takes time. There remains urgent need to mobilize research for LGBTQ mental health promotion at broader scale. The need for LGBTQ specific and sensitive programs remains a pressing issue, given persistent mental health inequalities for LGBTQ young people. So despite advances in individual level treatment, school-based programs, and state level policies that address LGBTQ mental health, there remain critical gaps in at scale, evidence-based prevention and intervention programs designed to support the positive development and mental health of LGBTQ young people. With the intention of stimulating research to cultivate action and progress translation, I offered 6 distinct but complementary perspectives for future work that I hope some of you will take with you. Although translation is a necessary step for our field, I'm learning as someone who was not raised in a translational science field that translational research is a difficult endeavor and that it presents new and frustrating challenges to our science and scholarship, but that these challenges may be overcome in partnership with LGBTQ youth themselves, community stakeholders, and teams of interdisciplinary and transdisciplinary scholars. And so by working through these challenges, we will ultimately provide another avenue for improving the positive development and well-being of LGBTQ young people. And with that, I would like to acknowledge my funders of this work, which I'm truly grateful for. And that leaves us 11 minutes for questions.
Thank you very much, Dr. Fay. I will open the floor.
Surely with 80 people here, there's at least one clarifying question I could answer for you.
Oh, I have a hand. It's Christine, so I'm going to go ahead and unmute her.
Am I actually unmuted? Specifically, the deficits in parent-child relationship quality. Can you speak a little bit more to what those deficits were? Were they tangible or intangible in terms of resources?
They were based on youth's perceptions of the warmness they felt from both parents. It was scaled to accommodate both single and or dual parent families. The warmth they felt from them, the closeness that they felt for them, how often they felt they could go to their parents if they had issues. It's a combination of those factors. It's a scale that's been fairly well used within the AdHealth data.
Great, thanks so much.
You're welcome.
You can ask a question, Dr. No. Dr. Simon has a question, so I'm going to go ahead and unmute them.
Hi, first of all, fantastic talk. That was really great. Early on, and I know I've seen this figure before, you talked about how youth are coming out at younger and younger ages, right? There's that whole concern. And I was wondering, is there any work looking at differences in age of coming out based on geographic region? Like, do kids in Texas still come out at a much later age than kids in Connecticut?
It's a great question. I have not seen any research that does regional differences. I think that would be a phenomenally interesting and impactful study. Wink, wink, K. But what I can say is that the youth risk behavior survey is collected at the state level. And when we gather data on sexual orientation and to the lesser extent gender identity, because these are optional modules, what we find typically is the rates of LGBTQ youth, even in states that are less affirming, like historically really less affirming, present the same percentage of LGBTQ youth that report, right, on a survey that they're LGBTQ. So that gives us some indication that these youth are acknowledging this and are willing to report it on a survey. What it doesn't tell us is if they've also told their parents about that identity. So it's kind of a proxy, but not a great one. But I have not seen anything related to regional differences.
Thank you. We have a question in the chat that thanks you for the fantastic talk and asks, when do you think interventions should begin? And what would the intervention look like?
For what outcome? For what population? I mean, I think the biggest takeaway is that we need to start earlier in the life course. We are seeing, no matter how young the data are that I have, I mean, we've gone down to 9 years of age now. We see that disparities are there, that differences are there. And so I think we need to rethink, right, what we think about when we're talking about intervention and prevention, right? So one of the things that we know is that including diverse images within elementary school classrooms, for example, normalize different family forms, right? I'm even just talking about just like step parent families versus, family of origin intact, two bio parents kind of thing, right? And so could there be a way that schools can increase visual diversity of LGBTQ people in the classroom? It's a very developmentally appropriate way to show, hey, there's different types of families out there, right? This is based on the work of Katie Clark. I think those kinds of things normalize that in general society and would be less likely to then have youth as they age impart stigma on the basis of that. Obviously, they might be getting that from home, but at least the school environment would normalize that sexual and gender diversity. And so I'm talking about there's lots of different levels of these interventions. Middle schools have been slow to, but are adopting gender and sexuality alliances, for example. Like there's lots of middle schools that have those now because they needed them, right? It wasn't just that you got to high school and it's like, oh, LGBTQ folks. And so we've seen that go younger. So that's kind of a big question to ask because I think with regards to what the outcome is, what the context is, We need it on across all contexts at very young ages and consistently as youth age into adulthood. We need many catchballs. We need, for example, doctors to be doing kind of expert brief screenings for substance use for LGBTQ youth in medical offices, right? All youth, right, in medical offices for substance use. We need to make sure that therapists have sexual orientation and gender identity on their intake forms, even when they are interviewing young people, right? 12 years old, they have some inkling about whether or not they know who they are in terms of their gender identity, their sexuality, right? And there's developmentally appropriate ways to ask these questions. And so it is a big thing, right? Lots of interventions and lots of strategies that span lots of different institutions. I don't want to feel like I'm punting that question, but that's kind of my initial response to that.
Thank you. We have a question in the chat from Christina Ross, and it's timely. In my lab, we were just talking about SGM kids in foster care just yesterday. So the question is if you have suggestions on how foster parents can better support youth in foster care and who may not want to support youth identity. I suppose that means support their SOGI.
So, yeah. We actually I have a colleague across the hallway here, Liz Aparicio, who's doing a study on this right now. She's interviewing LGBTQ youth in foster care. She's interviewing foster parents and interviewing foster care staff to try and understand the experiences of LGBT youth in care and what's working and what's not. The group at the University of Maryland, Baltimore, not College Park, University of Maryland, Baltimore Center of Excellence, and their Institute for Innovation and Translation. I would Google them. They have done a phenomenal job of creating an intervention for foster care offices to be able to implement within their system to be able to create better affirming environments in foster homes for LGBTQ youth. And this includes things like updating your records to be able to capture that data, to educating all foster parents on the fact that you have youth in your homes. They may be LGBTQ. This is how you support them. And so it's an educational strategy. Generally, it's a lot of question and answer, but priming foster parents to be prepared for the fact that they may be supporting or parenting a foster youth who is either questioning their identity or identifies as LGBTQ is really, really important, as is being really intentional with placement. If you know that a family is unaffirming for LGBTQ youth, you need to capture that data in your system, and you need to make sure that you don't place LGBTQ youth in that home. So that's a couple of different things to keep in mind as you're working with those systems. And I'm happy to share those links to you if, oh, wonderful. Perfect. Yep. Yeah. So be on the lookout for that study. I'm really excited to see what she finds.
Thank you. We have time for about another question. If anyone wants to get their burning question in before we end, raise your hand or type in the chat. Somebody asked if you can share your slides.
Yeah, I can share them with the folks at InCHIP, and I don't know how they distribute those, but I'd be happy to share. Yeah.
Great. And Josh has put a link to the YouTube version of this talk today in the chat.
Wonderful.
Okay, well, I will respect your last couple of minutes, and I just want to say thank you again so much to Dr. Fish for spending her time and sharing her very interesting ideas and future directions for SGM mental health in particular, or in health in particular, mental health. I think Dr. Fish is always open for follow-ups, and if anyone has follow-ups, they can. I think I'm putting her out there. You can email Dr. Fish. You can find her.
You absolutely can.
Stay tuned for the next InCHIP lecture series. Thank you all for spending your afternoon with us.
Thank you.